to introduction by Liz.
Yes, okay.
If we just say it's the intended order is Lizzie to go first, then Greg, and then Professor Nick Barker. Over to you.
Excellent, thank you. So I'm Lizzie Maplebeck and I'm the Associate Director of Strategic Change for the Suffolk and North East Essex Integrated Care Board. Change to ICB as an acronym. Previous to that we're a CCG, which some of you may be more familiar with. And I'm going to open the discussion about dentistry today. So the COVID-19 pandemic highlighted some of the issues in accessing NHS dental services, with 50% fewer dental treatments being delivered across North East Essex in 2001 compared to the previous 2 years before COVID. However, it is important to note that concerns regarding access predated the pandemic. Access to dental services is complex, and there are a multitude of challenges and barriers that influence an individual's ability or willingness to access care. It's important to recognise that no single approach will improve access. To do this. Suffolk and North East Essex is a particular pressure point with dental access, with 31% of our local population unsuccessfully trying to get a dental appointment in the last 2 years. That's 9% in England. Many dentists in Suffolk and North East Essex have handed back their NHS contracts. Reasons cited for this include the level of remuneration for the level of activity delivered. So dentists have told us it costs them more to deliver the NHS service than they are paid under the current 2006 NHS contract. And that contract is based on something called units of dental activity. So as well as receiving payments based on units of dental activity from the NHS England, dentists also charge a fee to patients receiving dental treatment. The fees are broken down into 3 bands, and these are set out in the report that you've got. They range from £23.80 for things like a checkup, up to £282.80 for complex work such as crowns and bridges. However, NHS dental care is free to those who are under 18 or under 19 and in full-time education, those who are pregnant or have had a baby in the past 12 months, those who are currently being treated in an NHS hospital and the treatment is carried out by a hospital dentist, and those receiving low-income benefits, or if they are under 20 and dependent of somebody receiving low-income benefits. So Suffolk and North East Essex ICB, which is Greg and I, received delegated authority from NHS England on the 1st of April next year, so we can directly commission pharmacy, optometry and dental services. As mentioned before, currently these are commissioned by NHS England. So this means from the 1st of April next year, SNE ICB will be able to take commissioning decisions about dentistry on behalf of our population. At this point, SNE ICB becomes the operational and legal owner of the function. We will be both responsible and liable for its delivery, with NHS England retaining overall accountability. Now, receiving delegated authority to commission and manage dental services will enable SNE ICB to integrate care and improve population health at place level. SNE ICB will have the flexibility to join up key pathways of care across Suffolk and North East Essex, leading to better outcomes and experiences for our patients. So this means we'll have the ability to manage all dental service contracts, and that includes the quality, incentives, service specifications, monitoring of activity and finance and outcomes. We will also be able to manage variations to contracts and undertake annual contract negotiations, and that includes agreeing local prices. We will also be responsible for planning, so that includes establishing new dental providers, the procurement and award of new dental services, and the closure of any current dental practices. Now, as we transition long-term from the recovery phase of the pandemic, we have a really unique opportunity to support the evolution of the dental system reform. We can use flexible and transformational commissioning, targeting access for those that are most in need, according to their individual clinical needs, personal preferences. So this, in theory, should address equality and address health inequalities. I'm now going to pass over to my colleague Greg, who will provide an overview of all of the work we're currently undertaking with NHS England in partnership. As I stated, NHS England are the current commissioners of NHS dentistry.
Thanks, Izzy. Good evening, everybody. I'm Greg Brown. I work for the CICB as a Senior Performance Improvement Manager. Previously, I was known as Contract Managers, where we write contracts and manage performance and do procurement and things like that. So about a year ago, we set up a dental task force within Suffolk and North East Essex, where we invited colleagues from Suffolk County Council, Essex County Council, Health Watch Suffolk, Health Watch Essex, our community dental providers, and our flowers dental providers within Suffolk and North East Essex, local dental committees, local dental network chairs, as well as NHS England commissioners into a room to discuss the issues that we were facing and look at some of the short, medium and long-term solutions. As an CCG at the time, we were able to secure some additional funding, but we've worked with NHS England to produce increased activity for routine urgent care capacity, which equates to about 20,000 units of dental activity across Suffolk and North East Essex. We've worked with care homes to promote the use of oral health within this area, and we have been linking in with courses that are being run by our community dental services and promoting those to healthcare professionals, not just in care homes, but across Suffolk, across North East Essex. And we're looking to do something very similar within Suffolk for this model. One of the key issues that was raised to us by Suffolk County Council and Essex County Council was that of looked after children in care. There's a legal responsibility on those councils to provide dental care for the children, and unfortunately they were unable to secure this. We've worked with NHS England and their clinical fellows to put in place a prioritisation pathway across the east of England, and there was a great clinical fellow named Catherine Liu who worked on this very hard and was able to set up a children care pathway across the east of England, where these children in care can actually access dentistry when they've been placed into foster care or adopted care, while the county council still have a obligation for them. There's been some additional changes to the national contract that's come through in the past 6 months that are being implemented as well, and the NHS England team are slightly ahead of the game as well, and implementing additional activity where providers can sign up to have what's known as unknown urgent work, where they can have an additional 10% of their capacity that they have is dedicated towards this group to ensure access, and work is now ongoing to make sure that that's not just urgent care but also routine and long-term care for these patients. We're working again with the children, with the community dental services for child education. So we're working on proposals to take to our board around supervised toothbrushing schemes and education for health champions in primary care to make sure that children in primary schools and nurseries are aware of the importance of brushing their teeth twice a day and seeing a dentist as clinical need arises. I say clinical need arises because originally it was 6 months that dentists you needed to be seen, but new guidance has been issued where it could be 9 months or 12 months. So it has has changed slightly. What we also know is people are struggling to understand what access and how to access these services. So we increased our frequency of our audits that we do as a ICB for 111 to make sure 111 are able to direct people to the right places. And there's also some new contractual changes that are coming in that require dental surgeries to update their information on the NHS website. And we'll be working with practices to ensure that we can capture that data and make sure we can point people in the right direction through all of the access points that we have within Suffolk and North East Essex. It may come as a surprise or it may not, but dental records and GP records aren't shared between one another. So it's very difficult for a joined up approach. And so we're really keen to pilot work that links the GP record with the dental record so that there's a holistic approach for patients within Suffolk and North East Essex. There's an opportunity that's arising with one of our community providers that are looking to update their IT equipment, and there's a possibility once that update has been completed that we work on a pilot subject to approval by NHS Digital of sharing records, which I think would be a really great game changer for those patients. Within North East Essex, within Mid Essex at the moment, so Winford Hospital, they are linking in much more with dedicated dental practices for oncology, rheumatology, and other patients that are having their treatments delayed, that are unable to access treatment, dental treatment within the community. And so that's something we're really looking for the outcomes of, and we'll like to be fast followers. And once that pilot has been successful. Lizzie, did you want to talk a little bit about the University of Suffolk and Essex?
Yeah, lovely, thank you. So if the vision of universal access is to be realised, we're going to need a dental workforce that can deliver it. So we need to ensure that we have the right professionals with the right skills, values and behaviours in the right place at the right time to meet the population's oral health needs. So we'll need to make use of the skills of the whole dental workforce, and that will bring us in line with the NHS long-term plan and the NHS people plan. So the ICB, in partnership with our local universities, our regional dental lead and both our county and borough councils are really keen to develop and deliver innovative ways of working that not only secures the dental workforce pipeline through education and training, but also contributes to the delivery of NHS services. The University of Suffolk have recently communicated their plans to open a centre for dental development, and that will enable leading edge education and training for the current and future dental workforce. Now, this centre will offer a wide selection of dental training opportunities for the whole team. It includes offers around postgraduate educational opportunities, as well as opportunities for newly qualified dentists, alongside the training of dental therapists, hygienists and technicians. The centre is also going to see the development of a clinical simulation and treatment facility, and that is to support the education and training of undergraduate students in dental therapy. So over time, the Centre for Dental Development will look to develop CPD opportunities, and that's for the current workforce, so offering a skills escalator and lifelong learning approach. Alongside this, the University of Suffolk is setting up a community interest company. They're doing that as a separate legal entity of the University of Suffolk, and that's to support their education and training through the provision of NHS dental activity across the region. So the University of Suffolk's offer will enhance the current local offer provided by the University of Essex, who offer training and education in dental therapy and hygiene, and also postgraduate CPD offers too. Now, I know Nick is about to present, so I don't want to cover anything that Nick is going to, so I won't go into too much detail. Just before I hand over to Nick, I do just want to reiterate the point that Greg and I are having to be very cautious with the information we provide, as we don't currently commission NHS dental services. I know I've said it, but I've got to say it a million times only, but that comes to us on the 1st of April. So if you want to invite us back on the 2nd of April, we will definitely come, and we'll be able to be a lot more open and thorough with plans that we look to do. But that's it from me, and I'll pass over to Nick.
Thanks very much, both Lizzie and Greg. Can everybody hear me okay is the most important element? Yeah, great. Thank you very much. First of all, apologies everybody for not being there. I've actually been in a national dental meeting with the local dental network chairs across England, so I couldn't make it to Clacton in time. So apologies for my rudeness of not being there, but hopefully I can take just a short while following on from what Lizzie and Greg have said, to say maybe give some background minded to making sure that everybody sort of understands the background, the landscape of what was there previously to where we're hoping to get now, as Greg and Lizzie have kindly elucidated. So my background is I'm a local dental network chair for NHS England, and I work alongside a colleague, Tom Norfolk. So between the pair of us, we cover the East of England region. So our region spans from Bedford, Milton Keynes, through Essex, Suffolk, Norfolk, Cambridgeshire and Peterborough. So we have a fairly large area that we oversee, and are obviously currently working our way towards the integration into the integrated care boards from NHS England, and a lot of work has been done on that. My other element, so that's a leadership cap that I wear. As you've been told originally, I'm a professor in oral health sciences and periodontology, which is effectively the studies of gum disease at the University of Essex, and I'll pick up on the University of Essex at the end, I think, to explain their roles. For reference, I'm actually a wet-fingered dentist. I'm a general dental practitioner. I work in a practice in Colchester, actually, so not far removed, and have done for many years. And I'm also a clinical advisor to the Office of the Chief Dental Officer, and indeed have been discussing with the local dental network chairs in the Office of Chief Dental Officer today the ways forward. So sort of hot off the press information, if you will, really. So very briefly, in 2006, there was a contractual change to what's been called the units of dental activity. And basically, this was a process that was meant to ease the patient charges, so patients could understand they only have 3 different styles of fee to pay. The biggest issue is that it was an activity-driven model. So basically, if you did something, you got paid for it. Well, in dentistry, prevention is the key, but you don't get paid for prevention under that kind of model. You're rather more doing the complex stuff, which really doesn't work. And that's why there have been various parliamentary reviews, and on at least 2 occasions, the contract's been declared not fit for purpose. Professor Jimmy Steele from Newcastle in 2009 wrote a review that looked at contract reform. So we brought in some contract pilots in 2011, which concentrated much more on prevention and using a pathway where patients were assessed for where their risk was and then sent down pathways of care depending upon where their greatest risk was. And that worked. Unfortunately, the pilots moved to prototypes, and then in April this year, the prototypes were actually finished, not taken on any further, which is really quite unfortunate, because it put us all back into the position of churning these units of dental activity, which really don't work, and that's why we run into the problems we have with dental workforce. So during COVID, as a local dental network, we went to NHS England and we've written a dental strategy. And there are 3 key themes to the dental strategy working across the whole of East of England, which is to get universal access for all who require it, to improve oral and general health, and I emphasise general health, because as the Chief Dental Officer will often put it, let's put the mouth back in the body, because dentistry has always been separate from general health, which is absolutely incorrect and needs rectification. And the final element is to improve the health inequalities that so many suffer, so vulnerable groups finding it much more difficult to get into dental services. And also during COVID, a flexible commissioning model was brought in. So what this determines is that rather than just as we have to at the moment, because the contract is a regulatory contract, to change it, it would need legislation. But what we can do is we can flex parts of the contract to provide different models. And that we provided many different models and looked at many different models to meet those 3 strategic aims that NHS England has signed off on. So some of the things that we've done is looked at a programme called Enhanced Health in Care Homes, where we work with those working in care homes to help look after their the residents in the care home and train the trainers, so those working in the care homes know how to look after our patients. We've brought in an urgent care model, which looks at 10% of a contract provided for urgent care for those who are not necessarily patients of the practice. And it's a key element to state at the moment. I see in various reports the terms registration. Well, registration and being registered as a dental practice finished in 2006, and yet the term is still used, and that's some of the issues. So we need to turn away from this, and that will be all part of this universal access of care. Then some of the other key elements, and one I'd highlight is, look, we're currently running research across primary care, one in diabetes, and we're actually able to test diabetic health in dental practices using a blood sampling machine. And that's key because in actual fact, with diabetes and gum health, they're bidirectional. So if you improve somebody's gum health, their oral health, they actually don't need a second line medication for diabetes, because it will actually improve their diabetic health. And same the other way around. So if diabetic health gets worse, then their gum health gets worse. And this is often little known by many people, and therefore, again, why we need to put the mouth back in the body. And as Greg has highlighted, be able to connect medical records and dental records together. So that's another key element, because at the moment, something happens in a dental surgery, the rest of the wider healthcare professions know nothing about it. They don't get to hear about it. 2 other elements we were looking at is children and children needing general anaesthetics is another important area, because those numbers are increasing. So we're bringing in a motivational interviewing study into the region as well, working across 4 centres in Northern Ireland, Liverpool, the North East, and then in the East of England. And we're also looking at a dental anxiety, so some prevention mechanisms to put into place with patients with high levels of dental disease and high levels of dental anxiety, which often prevent them from coming into the surgery. And on the final element, as Lizzie has highlighted, so at the University of Essex, we currently have the largest cohort of undergraduate hygienists and undergraduate therapists in the country. So hygienists are the ones who can work with patients to improve their gum health, with doing scale and polishes, many people would refer it to, so cleaning teeth and enhancing patients' oral health. And then therapists are similar to hygienists, but they have additional skills, so they can place fillings, they can extract milk teeth, deciduous teeth, and various other elements as well. So they are an important integer, because where we're left at the moment is the number of practices with NHS contracts or contract numbers is dropping, because currently young dentists are not necessarily interested in working in the NHS. The contract itself isn't, which is why we're bringing in all these reforms as well. And we have various other workforce issues. So the number of registered dental nurses has significantly dropped during the COVID period as well. So we're in a crisis point, but the aim is, if we get our strategy to work, then all of a sudden working in NHS dental services becomes more attractive, let's put it that way. So I'll pause there, because I've thrown an awful lot of information at you, minded to. There's probably a lot of what I've said may need further examination. So thank you very much again.
Yes. My first question has been to Lizzie. I've just been to ask about how long do you think it would take for these changes to have an impact in tendering? When are we going to see those people sort of coming through the university courses?
Yeah, so the first university course at University of Suffolk commences in September 2003. As Nick said, the University of Essex are already offering those courses. Nick, does the University of Essex offer the courses from September commencement?
Yes, there's a September and a January commencement for the various courses. The therapy course generally starts in the January, but some in September, and the hygiene is always in September, which is the normal university start point, as many may be aware.
Excellent, thank you. And the University of Suffolk are also offering the dental nursing as an apprenticeship to make it more accessible. So lots more people will be able to join that apprenticeship. So as soon as that course commences, students get their placements. So hopefully we'll be able to see an improvement in the workforce rapidly.
Thank you. So my other question was around the non-member briefing, because obviously we've got the committee here this evening, whether you'd be happy to come back and actually talk to all members, perhaps after April, you said when the contract actually changes.
Yeah, we'll come and talk to anybody who will listen to us. We're very passionate about this, so yeah, absolutely.
That's great. That's great. Thank you.
Opposed?
No, thank you.
I'll go back to April again. Maybe you want to start? Yeah, Councillor.
I was interested to learn about the new courses on offer because I wasn't aware of them. But what I would like to ask is, what is the entry requirements for these courses locally, please?
Thank you. So for the nursing apprenticeship at the University of Suffolk, it's 2 GCSEs. One is English and one is maths. Both now it's called a level 5, which is the equivalent to a C. So that's for the nursing apprenticeship. I'll have to defer to Nick for University of Essex therapy entry requirements.
Yeah, thanks very much. So University of Essex working up the scope of practice. So we have extended duties for dental nurses course, which is a course to give additional clinical skills to dental nurses. The only requirement for that is that you're a qualified dental nurse with at least 2 years of experience. Then at the next level, the hygienist course is 2 A levels. At C and above, I believe. I would need to check that. Or also if you've been a dental nurse or have an extended duties certificate as well. So it's a double feed-in, so it doesn't necessarily need an academic input. It actually needs a skilled input as well. So you can be a dental nurse and join the course without having the A levels. And that's a key element because it does allow this skills escalator to increase. Then for and that's what's called the extended duties is called a level 4. So if you take level 3 as A levels, then you have level 4. Then you have level 5, which is a foundation degree, which is what the hygienists are doing. And then to join the BSc, which is a level 6, which is a bachelor's degree, then I think the requirements are set at 3 A levels. Or as a skills escalator coming off the hygiene course, you can move into a top-up year to do the full BSc. So that just requires a qualification as a hygienist, either at the University of Essex or other hygiene qualifications also. So that's at a level 6. And then at level 7, we have a master's degree. So I'm the program lead on 2 master's degrees. One is called periodontology, which is for dentists and is about treatment of gum disease. And one MSc is for hygienists and therapists, which is called advanced periodontal practice, which is a level 7 degree. Again, just requires you to have gone through and got the qualifications as either a hygienist or a therapist, and then also have at least carried out 2 years of postgraduate teaching or postgraduate practice, and then move on. So what we've done is built a whole skills escalator where you can go from a dental nurse into a master's level postgraduate dentist or hygienist or therapist. Sorry, long-winded answer.
Because traditionally, am I right in thinking that it was Eastman College that was the famous one for dental hygiene and things like that, wasn't it, really? Because I can remember being told, well, if you're going to get a hygienist, make sure you get one that's trained in Eastman College, etc. So it's good to know that there is training available locally so we can grow more. Because I know my own dental practice in Frimton, which is private, and it's only in the last few years that we've managed to secure dental hygienist there, but he is Eastman trained, I have to say. But I think, so it's good that there's local provision now for training, because I do know that I have residents who have contacted me because they cannot get an NHS dentist, right? And two of them have got medical problems, and and really, what can you say? There just isn't the provision locally, so it's good that we're able to grow our own locally, because that gives more scope in the future, really. Because it's worrying.
Yeah, could I?
Because I definitely can afford the private sector. So.
Yeah, exactly. I have to declare a conflict of interest. I'm master's trained from the Eastman as well, actually.
Okay. Well.
But likewise, I'd say the University of Essex courses are as good as the Eastman, but I'm going to be slightly biased on that one.
Yeah, I think there's a dire need here, if I'm honest. I think you've touched on it, if I may say so. It impacts on, because I've personally had to have been on the mix up of this bone disease with a maxillofacial consultant, Mr. Ang, in Colchester Hospital. And, I realised from my own personal experience the importance of having dentistry, because as you rightly pointed out, you can highlight other medical problems, often is the keys. And I can remember 2006, I can remember my dentist in Frinton telling me, sorry, there was nothing NHS. And we had to go privately, and the dental plan desk was sitting there waiting for us to arrive, and so it's, but I understand the reasons behind it. So hopefully with commissioning, we will get that, people will be able to have dentistry.
I was going to say, I think, it's absolutely great. And, I completely agree with the aims that Nick has set out there for the strategy. And I think it is an absolutely amazing strategy that Nick has worked out. But, I completely agree with Nick as well. It's around prevention as well as treatment. And I think there's so much that we can do around prevention, to make sure that people do brush their teeth twice a day and use mouthwash and keep good oral hygiene, and it's just around education of people. Straw hose in primary schools worry me about how many children actually know how often this.
Well, I was going to ask that question, if I may, Chairman, because I'm a school governor as well, and the government a few years ago introduced the fact about cleaning teeth into primary education, because my niece, I have to declare, my niece is doing that for King's College London, and and with the elderly, she's concentrating both ends, school and elderly care. And I have to say, I don't know where schools are going to have these resources from to teach children how to brush their teeth. I thought that would have started at home with the parents in my family, but it really is a concern, isn't it? Because we don't teach people early enough.
Yeah, and that's some of our plans that we plan to introduce in the new year, is around linking community dental services with schools from kind of a public health perspective, to make sure that schools have the resources they need, toothbrushes, and education materials to actually teach students how to brush their teeth properly, which there's really good evidence to show that it does work in the 0 to 5 range. And I think it's about every £1 that's invested now in 5 years would save £3 worth of NHS treatment. So it's definitely worth doing.
Can I go to Councillor?
Yeah, one concern I've got really is, obviously we know that there's not that many NHS dentists around, and people who are on benefits from the fund, they often apply to legal instruction to an NHS dentist who refuses to, because his list is shut. So they're simple to a private dentist. Although an NHS dentist charges £23 prescription, they're quoting £100 plus from a private dentist. So what's happening is they're putting their own teeth. Now, would this alter in the future? Are you looking at this will alter in the future?
Yeah, so our ambition is to improve access to NHS dentistry. It's not for the private element at all whatsoever. We are seeing huge amounts of health inequalities, especially for those, you know, who are at the lower end of the socioeconomic scale. And it's dire, and it's just not okay, and it's just not good enough. Our ambition is to increase access for all who want or need it to NHS dentistry.
I know you're going to come back, but the examples I've got is people have relocated from Chelmsford. The two cases I'm thinking of that I've worked with, I couldn't help. I've got to be honest, they're exhausted every avenue, and I couldn't help them. They relocated from Chelmsford to here. Both have, you know, other health problems, and discovered that they didn't have an NHS facility in this area because they were all, and they think the one in Frinton in Antry Avenue quoting 4 or 5 year waiting list, would you believe? So I think there is certainly a demand and a need there.
Absolutely, absolutely. And, you know, we're not looking at creating dental practices that thin air because that would be very difficult to do so. But what will be within our power from the 1st of April is to get dentists to come back to the NHS.
Right.
So Nick touched on units of dental activity and that 2006 NHS contract, just not fit for purpose. And dentists are handing them back because they're just not able to make money to survive. So we will have the authority on the 1st of April to look at local prices, to look at how things are commissioned. So that's our aim. That's what we're going for.
Councillor Walton.
I'm going to say, Lizzie, you keep stealing my thunder here because I keep thinking of really good questions to ask. You keep answering before I ask them. So, my first question, while I think of another good one, my first question is to you, Nick. I'm really, really intrigued with this. What made you want to become a dentist?
That's a good question. My patients have asked that many years. Well, the first one they used to ask me is, "Are you old enough to be a dentist?" But I'm a lot older now, so I don't get asked it anymore. I always had an interest in dentistry. I had an interest in sciences. So it was between doctor, vet, or dentist, really. And I liked animals, so I didn't really want to be treating them. And I didn't really want to be looking at certain other parts of the human body. So I thought the mouth is safe enough, so I'll go with dentistry. So it was a process of elimination, really.
I'll say thank you very much for that, Nick. To say, because when I was growing up as a kid, not many people would turn and say, "Oh, I want to be an astronaut. I want to be this." Not many people turned around and said, "I want to be a dentist." And the only example I have of that is the film The Little Shop of Horrors. So sort of reaffirmed that sort of suspicion I have about dentists. But no, thank you very much for that. So, Lizzie, coming back to you. So you said like on the 1st of April, you guys take control back from. You have this ability to do that, and you're going to look at these contracts because the biggest issue I think everyone has, including myself, going through the whole COVID thing, and even after COVID, it is impossible for me to go and see a dentist, especially during the week. I'm unfortunately in one of those jobs where I can't take half a day off to go and see a dentist for a 20-minute checkup or something. You know, I have to have an entire day, and that means I have to book an entire day or lose an entire day's pay. And that's not affordable with what's going on in the world at the minute and what is to come later on down the line. So is this massive issue just the fact that you try and draw people back who are dentistry qualified, the nurses or the dentists and stuff, to try and get them back into what they were doing?
Yeah.
Is the goal?
Yeah, it is. So there are many a goal. One of them is to attract people back into practice. So, you know, you've got buildings that have already got dentists, used to offer NHS contracts, don't anymore. We would like to turn that back around and say we would like to invite you back to the NHS and we'll make the terms more appealable. But then we also have the potential to commission brand new dental services as well. So if we have a community interest company or a new company that comes to us and says we would like to offer dental services within your patch, we will have the commission and ability to be able to say yes or no to new dental services. So yeah, bring old ones back, create new ones. 2 points.
So if I can add to that, within North Suffolk, a little bit in East Suffolk, and in Norfolk, there's recently been a procurement for 8 to 8, 365 days a year. Dentistry has been received very mixedly by the dental community. If I'm honest, some of them and they were taken up on. Some of them they weren't. But you know, there are options to move towards 7-day-a-week working as well in the future. But I wouldn't say that would be kind of. I'd say that was a bit more of a medium-term ambition for that.
To say 300, who wants to work Christmas Day?
Who
wants to voluntarily do that one?
I wouldn't sign up to that.
Yeah. But no, as I say, no, I'm really pleased to hear you say this. You keep bringing all the good answers out. I'm running out of questions.
As I said, it was received very mixedly by the dental community. So I wouldn't say, you know, even if we offered 8 to 8, we'd actually be able to get it 365. But there are ones that are starting to appear slowly around the east of England.
Could also be lorry trucks working in kind of house.
But Councillor Clifton, your point is very valid, and it goes back to what Nick said about treating all have the same as we treat our health. You can get an out-of-hours GP appointment and extended hours GP appointment. So why should you not be able to if you have an oral health concern?
As I said, moving forward, the way the world is going now, and especially over the next few years, the recession's on the way. Getting decent paying jobs is a mission as it is. But even someone myself in a job, you know, Monday to Friday, I'm in work, I'm in the truck, I start stupid o'clock in the morning, I finish silly o'clock in the afternoon, evening time. I haven't got time to go to the dentist. And all of a sudden it's the weekend and there's nothing I can do, there's nowhere I can go. And I don't want to lose an entire day's pay to go for the privilege of seeing a lovely gentleman such as Nick for 20 minutes for him to say my teeth are fine or they're not good. But it is a massive problem going forward because a lot of people, you know, some people work 2-3 jobs now, and that flexibility of only being able to access services Monday to Friday, you know, a lot of people now, you know, they don't like their full-time job Monday to Friday, and then they'll have their second job, which is weekend work or evening work or something. It's not thinking. And a lot of jobs are now offering like the 4-on, 4-off scheme. I suppose that brings me to my next issue. With terms of looking at going back out into the qualified field who have left, how many sort of that number are you looking at bringing back, or have you not got an answer for that?
I haven't got an answer for that, unfortunately. I think we would need to do some form of market test when we're able to, when we've got the authority to be able to do so. We also need to enhance the conversations that we have with our dentists, such as Nick, to say, although Nick does offer NHS dental services, to say, why did you leave? What is it that you don't like about the NHS contract, and what is it that would attract you back? So I think we would need to enhance those conversations and do a bit of a market test.
I think Nick wants to come in on that point as well.
I think we've got.
I can remember if I
Okay, hold on a minute, please. Nick, you want to come in?
Yeah, only to put a hand, sorry, and I didn't want to interject amongst anybody else, so apologies for that. But yeah, the other thing we've got to look at, there's a current series of changes, and the other element is we're too wedded to getting in the dentist. We've got to think about the wider skill mix as well. So if you want to come in on a Saturday, it doesn't mean you have to come and see a dentist. You know, in fact, seeing one of the other of my team members is a lot more attractive than come and seeing me. So come and see them. They can do very similar things. They can provide similar care, and by sharing it across a greater number, it's a better way of working. So again, it just needs our ability to change the contract so that it actually gets to work for everybody, rather than everything being put through the dentist first of all and then spread the care wider. It's not the way to work in the modern world. Sorry, thanks very much.
Just on that point, there is some contract variations that are happening at the moment that are trying to encourage a greater skill mix as well.
I mean, I can remember, and all of us most probably can, when, you know, you had a dentist coming into primary school twice a year, didn't you? With the doctor to do the gas and air, and the dentist to do the checkups. And then the same with medicals. Every child had a school medical twice. I can't remember if it was 11 and 13. I know they had it 13 because they'd identify colour blindness and all that sort of thing. And, you know, which in those days you wouldn't be able to do certain professions. So are we going back to those sorts of days is what I'm asking. Do you think we'll ever get back to those sorts of days where those facilities will be available in schools and things so that people grow up used to going to the dentist, you know, and be checked up, and, you know, things will be identified early enough before the damage is done, basically?
I too remember the days, and the hearing nurse coming in as well and moving the blocks. Yeah, I can absolutely remember those. I don't know is the answer to that. I don't know if I can answer that at the moment, but I think it's something that we can take away and find out and bring back.
It was indicated all the indicators are that was good practice, really. It was dropped perhaps for financial reasons, or some governments dropped it, whatever the vote was at the time. But certainly, if there's real good intent to make a difference, it's why break something that's worked in the past, but why not revisit it, make it a regular thing so that young people's oral health is identified and prioritised.
And just kind of Nick, did you want to come in there?
Yeah, I was just going to come in quickly. It was a good way of working. There's a few issues that got in the way. There was a contract change, so the school services moved over specifically to what was called the community services, and then it came down to an epidemiological piece that was just about measuring the levels of disease that were going on in the schools rather than treating anything. And now we've got the CQC that I'm sure everybody's aware of, and the CQC brings in some problems with working outside of a dental practice because there's certain regulations that you have to be able to meet in order to actually treat people outside. But there are opportunities, and certainly there are some of the things. Some have talked about the supervised brushing scheme, which is a national scheme, and other schemes which can be introduced into schools and again can use that wider skill mix. So it's certainly feasible. It might not look like it used to, but it will certainly still work in an appropriate way, most likely. So yeah.
And from a contract point of view, I also think there's some flexibility in the contract to allow for paediatric cases to be targeted in specific surgeries to try and increase assessments and treatments. And I know that they're looking to pilot it in some parts of the country. I think with the university, I can't remember which one, I'm afraid.
Yes, could I just ask, something's just occurred to me as we were talking here, and especially about schools, which is our special subject. Won't it help regarding on some of the enormous health issues for the future if that is gone into the schools at a very early stage? The children might only learn it, but also the parents. And that is where I think it's very, very important. When you read the list that we've got in our reports, it's quite amazing the number of issues there are. My husband has had several of those, and that probably is because he had issues with his teeth when he was a youngster. So really and truly, this is quite amazing. If that does happen, I'm sure it will be beneficial to all of us.
I think your point about parents as well is really important, and actually maybe we should widen that and not just think about schools but child development centres, where mums or dads or parents go with their children at a really, really early age and have that education, the family support services. Thank you.
I think there's also, available toothbrushes and toothpaste for the parents. So things like getting toothpaste and toothbrushes into community supermarkets and food banks and things like that to make them really accessible for the community. I think is really key as well.
That's an idea. Having a dentist in the supermarket.
Yeah,
Specsavers in there now.
We've done it in Suffolk, not us personally, but Suffolk County Council have put a dentist in a supermarket in via Dent Aid in Bury, I think it was. But that again is a mobile resource that came because there was a acutely identified, and we're looking for kind of more longer term solutions.
Sitting opposite the chocolate and sweet jar, I don't know.
Can I ask you a question? I just want to it all with him. Now, I want to take it further on what I know about our dentists. That is going to the dentist and they have to pay out. They've got a lot of money, it's £64. And for one tooth, fortnight later, they go and spend another £64. Fortnight later, they go and spend another £64. People on low wages around here, people who are in Clacton, can't afford that. So is there any help anywhere? Is there any help coming anywhere to help these people? So they're pulling their teeth out, someone English said that, pulling your own teeth out of a pair of pliers. I know I'm all good, but I do
It's not awkward, Chairman, at all. I think the NHS bandings and the NHS exclusion criteria is set nationally. That's not something we will ever have the ability to adapt or change locally, unfortunately. That is set by government. So
Yeah, okay. I just wondered if that was you know, what happens to people.
yeah, and there are a number of people who will be excluded from the payments, and I would encourage members of your constituency to visit the website to check to see if they are part of that list and they can be excluded from paying, because it isn't just you're on low income or you're on benefits. There are a number of different areas, and there is quite a clear website which will point them out. So, and I'm happy to send you the link to that, Chairman, if you'd like to share it with your constituency.
Thank you very much. Anyone else?
I'll let Nick go first. And
I was only going to come in very quickly. The other element that again we need to emphasise is say for examples like that. What we really need to do is get that prevention piece in, because that would prevent the next £64 and the next £64, because the way it currently works is obviously it works better by actually carrying out additional pieces of treatment rather than needing to prevent it because of the peculiarities of the contract. So emphasise that again. Thank you. Sorry to cut across.
Thank you.
No, thank you very much, Jim. I just like to come in and just today. I came in today fully expecting to give these guys both barrels. I really did, because I was going to turn around and say, look, I haven't seen a dentist, I can't see a dentist, why can't I see a dentist? Rah, rah, rah. But you guys have come in, you've given a really good performance, and it's given a really, really positive outlook for the future. Lizzie, I'm absolutely blown away with your enthusiasm on this whole thing. I can see that you actually really feel quite strongly about this. So it's really refreshing to see, and I'd like to thank you all for myself for coming down tonight and agreeing to do this. I think moving forwards, you know, unless anyone else wants to continue the conversation further, I think, like we've discussed, what's the acronym for you guys?
ICB.
ICB. Right, so they take control on the 1st of April. I think we ask these guys back maybe July time. Let them get their feet under the table with this. Ask them to come back July time and ask for an update then for the next working party, or they could discuss it on the next thing account on the next scrutiny committee as it's formed after the elections.
One would hope that whoever's in, whoever our members then would still be committed and totally interested in this subject, if I'm with you, because it affects all our residents, this dentistry, like medical does.
It affects all of us around this table as well. It affects me. I can't get in to see my dentist because...
That's because you're too busy working, you've said.
Yeah, this is true, yeah. It's just a thing of life. You can't get in to see a dentist. I'm one of those people. I won't go and see a doctor. I won't go see a dentist unless I feel I've got a problem. I don't like to be a burden. And unfortunately, I've fallen out of that annual thing where you've got to go and see a dentist in a year. Otherwise, no longer in the books. It's an absolute nightmare to try and get back in. But it's like I said, you guys have noticed this is the problem. You've noticed there's a lot of problems. You notice access for people is a lot of problems, especially with what's coming down that might work for the future. And you're addressing all these things. You're putting all these wheels into motion. You're going out. You're asking previous staff and qualified members, what's it going to take to get you back? You're looking at ways of getting those people back into current dentist practices, the resources to look at opening new ones. Honestly, don't know whether I can have a crack at you on this one.
I think the good thing is this is a government initiative. I mean, for some time we've heard now the government made a pledge that they were going to increase NHS dentistry and make it more readily available. So it's driven nationally, as you've said. They set the prices, they set the whatever. What they need to do is give contracts attractive enough to dentists to attract them back in, basically. Let's be blunt about it. I think Nick mentioned the 206. I know my own dentist left to go private for that reason, because there was no incentive to remain in the NHS. It's not that he wasn't committed to dentistry, he was. But at the end of the day, there was a better means of remuneration, and that drove him into private practice. And of course, we also know that private practices, they go into more cosmetic work now because they're doing fillers, face fillers, or you name it, everything, aren't they? To be honest, it's just a growing industry. You know, it's a really growing industry. So
Whatever buys the Bentley.
I think it's really important, because I think the most important thing is health. I think it's, Nick touched on it. It identifies, I know I had 2 members of my staff who were and things with and was malignant, little ulcers in their thing, and had they not gone to the dentist, they would not have been picked up early, because nobody would have thought to go to the doctor about a little ulcer in the mouth, you know. So, and you know, hey presto, they were 100% cured because it was caught in time, purely because they were doing their 6 monthly checks, to be frank. So
Okay, hopefully. Please, you want to ask?
Just, I'd be interested to know, when the ICB take over, what metrics will be used to determine how successful you are going forward?
That's a great question. So, we are looking at approaching 2 key outcomes. One is the increase in NHS dental access. So how many more people can access an NHS dentist? And the second is addressing health inequalities. So looking at specific groups of people that struggle the most or are less likely traditionally to attend a dentist, and increase that as well. So they will be our 2 outcomes. We will also be looking at Nick's national strategy that he has been working on as well. And Greg was working with the local dental task force to create a local strategy, which will set that out in writing and be published and made publicly available.
And just to kind of build on Liz's point, it's not just, you know, we're going to be looking at general access, but we also will be looking at urgent access, because obviously we know that people who are in pain, you know, do have time for work, do struggle to get access and treatment to get out of pain, even if it is just to get out of pain and then go back and 2 or 3 months later to actually resolve the issue routinely. But it is also the amount of urgent availability of urgent care as well is one of my key aims as well via this process.
can I ask one question? You know, for example, that abscess, a mouth abscess, tooth abscess. You know, I've seen people, adults crying with an abscess.
Yeah.
You know, some of us, I haven't had one like that, but I've seen people crying. So people who don't have the, you know, where do they go say Christmas Day? We mentioned Christmas Day or Boxing Day or whatever, or any other day, if they haven't got a regular dentist. Is there an emergency that everybody can have if it was something like an abscess or whatever?
So there is a 111, the 111 service
Okay.
has a number of dental nurses, and then there's an out of hours service that's commissioned.
Okay.
But it is 7, 9 appointments a day.
Because that's
very
acute
small.
pain, isn't it?
Yeah, and well, it's more about dental trauma.
Yeah.
It's
an emergency.
Yeah, emergency trauma. Pain is. I'm not sure how to describe this, Nick. You might be better than me, but some pain is a dental emergency, and some pain isn't a dental emergency, depending on the dental review at the time. I'm not sure I'm saying this properly, Nick.
Yeah, there's basically some guidance out there that sets different dispositions, basically. So depending upon the level of urgency, nothing in dentistry is actually an emergency. Emergency means it's immediate threat of to life. So the majority say an abscess would be a 6-hour disposition, so needs treatment within 6 hours. Then it increase up to 12, 24, 72 hours, depending upon the specific situation that's there. So NHS 111 drive that, so they'll put into account, or they should put into account, services. But again, on certain days, bank holidays and whatever, it's a relatively limited access. So that's certainly something we would need to look at. And going back to the very good question about metrics, and obviously in my research mode, yeah, it's very much my kettle of fish. I think there's a few areas that we should look at, and certainly that we've looked at as far as East of England are concerned. So 3 metrics we want to consider: a clinical one, which is what sort of treatments are being undertaken, how frequently, and indeed are they the right ones. A commissioning element, which is actually saying, are the practices doing what they're commissioned to do? Are they open at the right hours? Are they seeing the right patients? Are they seeing a mixture of patients, etc.? And a key element that we want is looking at health outcomes, and this is something we're working with the International Dental Federation on, of something that's called the International Confederation on Health Outcome Measures, which asks patients questions about, do they feel that their benefited them? Did they get it at the right time? How are they better able to function? Are they better able to speak? So there's 3 different areas that we very much need to look at for whatever we do going forward, so that we capture all of the data and make sure what we're actually doing is serving what it should do. Because if it's not, then start all over again.
And just to come on to Nick's point, yeah, just to go back to my point at the beginning, we have set up a dental task force with quite a lot of providers and commissioners and around the room, and so we'll definitely be using that that task force to drive this forward as well.
Thank you. Keith, you want to come back actually?
If I may, just you've told the committee that it was about improving access and improving emergency access and addressing health inequalities. I don't know whether there's now fully worked up metrics or that can be shared with the committee, or that we should expect those within 3 months, 4 months or whatever, so that they can then be aware of them and consider them.
Thank you. No, they're not fully worked up. They're not actually even drafted yet. The reason for that is because we have to wait for our experts around the task force. Nick is one of the experts that sits around and Greg's task force to develop that. What we need to do is make sure we co-produce it. So we could, as commissioners, sit in a dark room and create these metrics by ourselves, but actually that wouldn't be the right thing to do. So we would like to co-produce it with our experts, our dentists, such as Nick, and also Health Watch and some users by experience as well. So when that is ready, and as I said, it will be publicly available, we'll make sure you have a copy of that.
Right, anyone done? Yeah, so I'll let our guests go. Thank you, Nick. Thank you, Lizzie. And thank you, Greg. Thank you very much.
Thank you very much for having us, and we look forward to coming back again. Thank you.
Thanks all.
Thank you.
Thank you very much. Thank you.